Good afternoon, everybody. Can you hear okay? I can hear my voice in the echo. That's good. Okay, firstly, very welcome, and welcome to Peter Mac and to our inaugural nursing seminar series, with a joint between Peter Mac and our colleagues at the University of Melbourne. So I'm really pleased to be joining you today. My name is Andy Dimmick. I'm the Chief Nurse here at Peter Mac. I'm a cancer and intensive nurse by background, and I've been at Peter Mac for about a year and a half now. So I'm really pleased to be back home after spending 21 years in the Northern Hemisphere, and now very at home with my colleagues here at Peter Mac and at the University of Melbourne. So firstly, I'd like to acknowledge the traditional owners on the lands that we're meeting today. For myself, it's the Wurundjeri people of the Kulin Nation, and pay my respects to elders past, present and emerging. And for those that are joining us online today, again, to pay my respects to where you may be joining us from. We're very blessed and lucky to work in a wonderful state and country that's been looked after for many thousands of years by our First Nations people. So today, we are going to have our inaugural session today. You'll have various members of the team coming to speak to you. So I'll introduce the team with us here today. So they'll do a self-introduction in a moment. So Professor Marie Gertz is here from the University of Melbourne, who will start with our introduction. And as we go through the team, they will also then introduce themselves. So as we're going through today, I'm also going to open up an opportunity for you to ask any questions online. So to do that, you use menti.com, menti.com. So if you log on to that page and then type in 7368-4942. So just repeat that once more, 7368-4942. And then you'll be able to type in particular questions, and we'll monitor those, and we'll be able to answer those as we go through the session. So as I said, first person to come up and speak to you is Professor Marie Gertz from the University of Melbourne. So I hand over to you.
Thanks, Andy, and thanks everybody for taking time out of your busy day at the end of the day to come and join with us in this seminar series that we're opening today. It's terrific to be here at the Peter MacCallum Cancer Centre, and I too also want to acknowledge the traditional owners of the land on which we're meeting today, which is the Wurundjeri people, and pay respect to elders past, present and emerging. Just a little bit about this event series that we decided to host together with Peter Mac, and it's great to see nurses from both the university and our other partners over at Royal Melbourne, some people from the children's here in the audience as well. But back in 2020, there was a horrible thing that happened, and we all went away and worked at home. And during that time, we decided to create a seminar series, which we conducted completely online. And through 2021, 2022, we continued to have great success with our online webinars. But now we're back on campus. We're trying to really reconnect in person. So we've learned a lot about technology, about Zoom, and now we're learning about hybrid events. And so it's terrific that we can have people in the room and also online, and hopefully this will be the start of something great for our partnership in the Parkville precinct and beyond. Now, this is one of four sessions that we'll host throughout the year, and we're focusing on equity in healthcare. This year we've decided to look at that in terms of both exploring the design, implementation and evaluation of nurse-led models of care that address equity and access in healthcare, particularly focusing on vulnerable populations. And we're also going to look at strategies to optimise nurses' scope of practice to enable better access to healthcare. But most importantly, this is a time in person for us to connect and to network and to open up conversations with our colleagues in the clinical environments, as well as across the university partnerships. So I think it's a great time for us to get together and also have a drink and some refreshments afterwards. So tonight we're very lucky to have with us Associate Professor Jacqui Richmond. And Jacqui is going to be presenting on her topic, which is lifting the invisibility cloak, the importance of nurses in their efforts to eliminate viral hepatitis by 2030. I'll just tell you a little bit about Jacqui. Jacqui's actually just an honorary of our department as an associate professor. She's worked in the area of viral hepatitis for 25 years, mainly in education, social and health services research, and also in policy development roles. She's a registered nurse and she completed her PhD in 2006. She currently works at the Burnett Institute as a workforce development and health services delivery program manager for eliminating hepatitis C, the CEC Australian Partnership. The focus of Jacqui's work primarily has been building the capacity of the health workforce to test, treat, and to manage the healthcare needs of people living with viral hepatitis. So I now warmly welcome you, Jacqui, to the podium to present this lecture. Thank you.
Thank you very much, Marie. I'm beyond honoured to be here. I met my, probably this time last year, I think, thanks to a colleague of mine, Sally Watkinson, who is a talent scout. And I found Mai and got her to speak at one of our events last year. And since then, it's been a life of adoration. So I'm absolutely so honoured to be here to present this inaugural presentation. So I do sit and I wear a couple of hats. I'm not an associate professor. I'm just have a PhD. Thank you for the promotion. There were many people that emailed me actually and said, "What? You got an associate professorship?" I said, no, let's not get carried away. So I do work at the Burnett Institute, and 2 weeks ago, I started working at one of the public health units down in Geelong. A strategic move for me because in Geelong, they have treated 75% of people living with hepatitis C. So I'm very interested to see what levers we can pull in an environment that is very close to eliminating hepatitis C. So these are my disclosures. And I'd also like to begin by acknowledging that we stand and sit today here on the lands of the Wurundjeri people. This is artwork that we had commissioned at the Burnett Institute. And if you ever have the opportunity to go to the Burnett on level 3, this is a huge mural as you get out of the lifts. It's absolutely beautiful. And I find myself standing there at the beginning of a work day, just staring at it. It's really hypnotic. This is Bunjil. Bunjil takes the shape of a wedge-tailed eagle, and he's the creator of the Kulin Nation. And Bunjil has 2 rules when you are on Wurundjeri land in the Kulin Nation, that you obey the respect for the land and that you treat the children kindly. So I think we all, I certainly try to live those every day, because I also at home sit on the lands of the Wurundjeri people. So I'd also like to acknowledge that Aboriginal and Torres Strait Islander people are disproportionately affected by viral hepatitis. We have a very, very long way to go in terms of closing the gap, in terms of equity of access to Hep C care and hepatitis B care. Hep B care, I must say, is being delivered extremely well in the Northern Territory, to the point that if you're in the Northern Territory living in a remote Aboriginal community, you are more likely to be on hepatitis B antiviral treatment than you are if you're in downtown Melbourne. So we have a lot to learn about things that are going on and creative, innovative ways of delivering healthcare. So did everybody know you can actually buy an invisibility cloak? I have a 14-year-old, a 13-year-old and a 9-year-old, and let me tell you, they know that you can buy an invisibility cloak, and I know that I can also buy an invisibility cloak. I was disappointed the other day when I realised that this invisibility cloak is only really real when you're looking through the app, which my children do most of their time, particularly the older ones. They're just connected to their phones. But an invisibility cloak is something that you can buy, and it can be very handy. I'd love to wear one on occasion, but they can also be very, very problematic. And I feel for nurses working in hepatology, the study of the liver, and for nursing more broadly, we've got to shirk that invisibility cloak. We have to be seen. In hepatitis C, we do have a goal to eliminate hepatitis C by 2030. And it has been firmly said numerous times that it is the nurses that are going to eliminate hepatitis C. So we need to take that invisibility cloak off. But it is something that we have been dealing with for a very long time. So I'm a 3rd generation nurse. My grandmother was a nurse in World War II in Papua New Guinea, and only recently has her invisibility cloak come off as we recognise the role that nurses and women have played in our world wars and our other local conflicts. My mother, in the middle, talks regularly about the fact that she felt invisible. I don't quite know how she felt invisible with that hat, but she got caught on things, I think. But she talks about being the handmaiden to the doctors, to the other members of the healthcare team. And then me, I'm the third generation nurse. And sometimes when my grandmother, my mother and I would be sitting around the table, my grandmother would say, Jacqui, it's like you're in a different job. Are you really a nurse? And I'd say, yeah, I am. I am actually a nurse. This is what we do these days. And she would be absolutely astounded. I think we've worked very hard for that recognition and to shirk that invisibility cloak, but we still have a long way to go. And I'll be providing some evidence of that and how much we have still to do. So just a bit of background, because I can't help myself. I always have to talk about hepatitis C because I'm always looking to recruit new people who are passionate about hepatitis C, as passionate as I am. So it's a virus. It's spread through blood-to-blood contact. The majority of infections are a result of sharing injecting equipment. So about 80%, we think, are spread through sharing of injecting equipment, and then there's other blood-to-blood contact that makes up the rest. At the end of 2020, we think there were about 120,000 people living with hepatitis C. So you can see that that is different to what was at the end of 2015. We have treated close to 100,000 people and cured close to 100,000 people in the last 6 years. So we are certainly on our way. In new infections, because the pool of infection is reducing, therefore we've got fewer new infections occurring, and this is a really important marker of our elimination strategy. And as you can see, we've got about 100,000 people were treated between 2016 and 2021. And I'll talk about the cure in a moment. And that leaves us, we think, approximately with 40,000 people that were living with hepatitis C in Victoria in 2016. So in Victoria, this is notification data that has been included in the in the state strategy. So I always think when policy documents put these numbers forward, you've got to present them and represent them over and over, because we've got to make sure that people remain accountable to these numbers. So between 2016 and 2021, about 10,500 people were notified with hepatitis C in Victoria. You can see the gender breakdown, more males than females. And we certainly are seeing that reflected in the treatment data, with special effort now going to find the women living with hepatitis C, because often they are not coming forward for treatment. 73% a result of sharing of injecting equipment. You can see that 31% of cases were born overseas. Once again, taking the opportunity just to if we've got any primary care colleagues or anybody who's in a situation where they can be documenting country of birth, documenting Aboriginal and Torres Strait Islander status, this information is so important for us in terms of our planning. And you can see that 56% of people, country of birth was unknown. So we've got still lots of work to do, and I'm really hoping that the devolving of notifications to local public health units and that follow-up process that will be taking place will mean that we don't have so many unknowns in that category, and we can better shape and plan our services to the populations that need it. People born in India and Vietnam were the most commonly common countries of birth for hepatitis C notifications in that time period. But Aboriginal and Torres Strait Islander people were 17 times more likely than non-Indigenous people to be notified with hepatitis C. So we absolutely have to do something about that number, but we also need to look at why that is occurring. And that is because of the over-incarceration and the over-representation of Aboriginal and Torres Strait Islander people in our prison systems. And at the moment, hepatitis C in the prison, the prison is just this engine that people continue to become reinfected over and over again, because there is a lack of harm reduction and a lack of understanding of what is going on in the prisons. Actually, I don't think it's that we don't understand. I think it's that we just don't want to understand, because it's politically a hot potato and it's a very difficult issue. Majority of people are living in metropolitan Melbourne, and the majority of diagnoses were being made in general practice clinics. So that gives you a bit of a snapshot as to where we are in terms of hepatitis C in Victoria. So I guess Sally and I were at a meeting on Thursday, and one of Sally's colleagues, who's a mental health nurse practitioner, who is writing scripts for hepatitis C and the cure, got up and she said, "Why on earth wouldn't I get involved in this? I'm curing something. I'm actually getting rid of a condition. What an amazing motivator in an environment where you're used to working with chronic disease." So we have 2 drugs on the market. These drugs in various iterations. This is where we've landed, but the drugs, direct-acting antivirals, first became available on the PBS in 2016. So we've got Epclusa, which is 1 tablet once a day for 12 weeks, Mavorite, which is 3 tablets once a day for 8 weeks. And we're looking at 95% cure rates. Absolutely, absolutely amazing. So very few side effects compared to placebo, and the side effects that are experienced can be managed quite well. Vosevi is the medication that we save for if the treatment is ineffective, so in less than 5% of cases. So we have the armoury. We talk about it all the time. We've got the things we need. We've got the cure. We've now rolling out point of care testing, so finger prick testing for diagnosis of hepatitis C, results back in an hour. We've got the knowledge and we've got the know-how to get this done, but we still just don't have the capacity on the ground to actually roll this up and roll it up and scale it up. And that's what we're going to need, because we have committed at a local and a national level to the WHO hepatitis C and hepatitis B, so viral hepatitis elimination targets by 2030. Where are we up to now? 2023. We were one of the only countries in the world who was set up well. We've got free drug, we've got wide availability of prescribers, the medications can be dispensed in community pharmacies, we're devolving the care outside of the hospitals into community-based settings. And yet, at the current point where we are today, we are not going to reach our 2030 target. So we have to start thinking about how we are going to do things differently. And that's why I'm always looking to make new friends, because I always think you all have good ideas that we may not have thought about. And even if you don't work in hepatitis C, you don't have to. There's plenty for us all to do. And that's what I'm going to be talking about. So this is the example. We all have a role in eliminating a bloodborne virus. So this is data that's been produced by colleagues at the Doherty. So between 1997 and 2016, you can see that 44,000 cases of hepatitis C were diagnosed in Victoria. 1/3 of those were diagnosed late, i.e. they had a diagnosis of hepatocellular carcinoma, HCC, or decompensated cirrhosis within 2 years of their diagnosis of hepatitis C. And although we have seen this improve, it is still happening. It is still happening where people are diagnosed first with HCC, then with Hep C, a curable condition. What the data showed us was in the 10 years prior to the diagnosis of hepatitis C, or the HCC, decompensated cirrhosis diagnosis, 99% of them had visited a GP. 94% had been in hospital. They'd been admitted. 89 had had a blood test, and 77% of them had been to a specialist. In the 10 years prior, nobody had thought to test for do a bloodborne virus screen, Nobody had explored whether or not there were any risk factors. We don't know why they were being admitted. We don't know why they were having blood tests, but these are missed opportunities. And we need to make sure that everybody in the health system has that capacity to think and not be siloed. As we're all talking about this all the time, aren't we? We don't just focus on our own condition. We need to be holistic in our approach. But this is really heartbreaking data, because once, as many of you will know, once we diagnose HCC, if it's advanced, there aren't many options aside from palliative care. But this is something that we could absolutely have prevented. So that is, by way, a little bit of background as to where we sit. So this is where my worldview has come from over the last 4 years. So Paul Ramsay Foundation is a philanthropic organisation that funded the Burnett Institute back in 2019 to set up an Eliminate Hepatitis C Australia partnership. So this was a framework, if you like, for hepatitis C elimination, to bring people together, to have a shared vision and to do some cool things. And that's exactly what we did. So I managed the workforce development and health service delivery component, but you can see there were other components of this project, and some of them that are still going. Back in 2019, for 3 months, I left my children every Monday morning and got on a plane and travelled to one of the red dots around the country and met people and talked to people. It was an absolute privilege to hear where were people travelling and how were they travelling and what did they need and what were they thinking at this stage after having had the direct-acting antivirals for 2 years, 3 years at this point. We met with jurisdictional implementation working groups, viral hepatitis elimination committees, and everywhere we went, there was not one nurse sitting at the table. And I kept saying to my colleagues, I don't know how they expect us to do this if we haven't got the people in the room who are going to do it. So we'd go out and we'd meet with all the nurses separately. And I worked with a lot of epidemiologists, and back then they were just epidemiologists. They weren't cool, you know, before COVID. Now we have to bring them back down to earth on a regular basis. You are just an epidemiologist after all. But my epidemiology colleagues were convinced, and absolutely, I think they already knew it. But after speaking to these committees and then speaking to the nurses, it became very clear what we needed to do. So my component was allocated $4.7 million. My boss is she's an epidemiologist. She's also an infectious diseases and public health physician, and so she does maths in her head. And so she came up with some really interesting calculations as to how we divvied up the money. But essentially, every jurisdiction got some of the $4.7 million. They gave expressions of interest internally within their jurisdiction, and then they were pitched to us. And, you know, by the time they were pitched to us, the decisions were made. So we funded all of these projects. So there were 21 in total. And they ranged from workforce development and capacity building activities through to client engagement strategies, such as funding peers, people with living experience via the Hep C or injecting drug use, incentives or financial reimbursement for people to be tested and treated, and then models of care. Every meeting I went to, every jurisdiction, every place I went, I just kept hearing the same thing. We just need a nurse. And I said, isn't that fascinating? You just need a nurse, and yet there's not one nurse here in the room. Yes, but we just need a nurse. If we had a nurse, they'd be in the room. So we just need a nurse became the catchphrase for 2019. And we then went on to fund nurse-led models of care in the ACT, Northern Territory, Queensland, South Australia and Tasmania. And I'll go into them in a little bit more detail in a moment. But to look at where this nursing role evolved. So hepatology nursing has been going for at least 30 years. So hepatitis C was first identified in 1991, and we began treating it with 3 times a week interferon. And we made people very unwell with the treatment. and about 13% of them had a positive result. We didn't call it a cure back then because we weren't entirely sure that the virus was gone. I started working as an interferon nurse educator in 1998, and I used to educate people on how to give themselves a subcutaneous injection into the fat of their tummy. For many people, they had been infected with hepatitis C due to sharing of injecting equipment. So for me to then tell them that the way for you to get rid of it is to give yourself another injection was, for many, very, very traumatic. They weren't often that unwell. They didn't feel unwell, but I tell you what, 12 weeks of interferon will do it for you. Many of them felt dreadful. So we were very focused. We were hospital-based. We were very outpatient focused. And we had to really trust the people that we were looking after. So people set up hoops and loops and patients had to jump through things. And if you're 3 strikes and you're out, we can't trust you, you know. So we were treating a particular type of person who could make it to the liver clinic based within the deepest, darkest bowels of St Vincent's Hospital, which is where I was. And this was the way until mid-2000s. We added antifreeze, as I like to call it, to interferon, and it was pegylated. So pegylated interferon became a once-weekly injection. We gave ribavirin. To this day, we're not quite sure what ribavirin does, but it certainly improved response rates. So now we're thinking about 40% of people getting rid of their hep C. But once again, now we're introducing things like mental illness and people, depression, suicidal ideation. This was a chemical imbalance that the interferon was causing. And so we became jacks of all trade. We were working with people. At that stage, they weren't terribly marginalised because they were in the tertiary hospital system. But they were very fragile for the 48 weeks that they had to give themselves these injections and take the tablets. So as hepatitis C evolved, we then started having direct-acting antivirals were coming in. So I had 2 children in quick succession in 2008 and 2010, and I came back to work and took one look at what the direct-acting antivirals were doing at that stage. They were sort of they were killing people, but not that many people. But I didn't sleep very much because I had these 2 children and I didn't really know which way was up. And I said to my colleagues, I can't do this hep C thing. This is too stressful. I've got to go to hep B. So I went and ran hep B community-based care, trying to get people with hep B out of the hospital. Meanwhile, my colleagues like Sally and others stayed there and they kept going and they got through those first rounds of DAAs. And then we got on to the second iteration and then the 3rd generation. And now we're left with these amazing drugs that in a very short period of time have gone from not great to, mind you, they were good at curing hep C, but they weren't too good at skin conditions and other things that they caused. So we then have seen the expansion of hepatology nursing, not only in hep C, but in hepatitis B, advanced liver disease, excellent evidence to support nurse-led care in advanced liver disease, that we see fewer admissions to emergency, fewer frequent flyers, because things are managed well. Education, the patient is well informed about their health and their condition. And hepatocellular carcinoma care, a very, very important role these days in the liver clinic because there is increasing rates of HCC, and this is a multidisciplinary team arrangement. So we have a very important role of the nurse there. And then the next epidemic of liver disease, which is fatty liver disease. So fatty liver disease causes inflammation, which can then go on to lead to cirrhosis and the development of liver cancer as well. So there's lots of hospital-based nurses doing that. Meanwhile, that's all happening in the hospital. And I'm, along with my other colleagues, thinking, I don't really belong here anymore. This is not really the work I want to do. I'm not really interested in fatty liver disease. I think I need it out there. So more and more, we saw that the numbers of people coming to liver clinic were dropping because it was harder and harder for people to find their way there. So we had to start moving and start getting out to where the people were. And that's certainly now where hepatitis C care is predominantly spread. However, I did have a conversation with a colleague the other day who said, oh, hep C is not a problem. We don't have any of it in our liver clinic. And I'd say, I would hope not. I would hope there is no hepatitis C in your liver clinic because I would hope that it's all being treated in the community, in places that are close to people's homes. There is no need for a person with hepatitis C, unless they have advanced liver disease or liver cancer, for them to be taking up an outpatient visit. So we have these consensus-based guidelines, and these were developed in 2000, and gosh, it seems like a long time ago, didn't put the year there, 2019, I swear it was way long before then. But these are consensus guidelines. We deliberately made them so that they're just a one-pager. The font got quite small after a while, but I was determined to have them as a one-pager flip-over thing so that people could be guided, because you don't need to do all of it. You can pick and choose. There are some things that might fit very nicely into your scope of practice, and there are others that you go, no, that's probably a bit hair-raising for me. I'm not going to. I just don't have time. So the role has been very well defined in Hep C and advanced liver disease and liver cancer. Hepatitis B, which is a passion of mine, is certainly still lagging behind. So we still have a lot of work to do. But even since 2019, the nurse's role has expanded and has changed. So nurses now are way more interested and available and involved in offering hepatitis C testing and screening, for that matter. So doing mass screening events. A lot more involved in providing harm reduction education, safe injecting techniques, making sure that people who are at risk of hepatitis C transmission have the knowledge and capacity to prevent transmission, because that absolutely can be prevented. We have a real focus now on linkage to care. I argue that there's no point testing somebody if you don't have a pathway for that person to be connected. And so it is requiring extraordinary effort by many of our nurses who are out there really doing that job at the coalface. They're a long, long way away. So Sally, who I want to, you wave, Sally, I know you're more, don't shake your head at me then, Sally. That's the one. So Sally Watkinson is our only nurse practitioner in viral hepatitis. She works at the Royal Melbourne Hospital, and Sally spends her Tuesday afternoons out in sunshine in a bus on the street. You're a long, long way from home out there, Sally, aren't you? You're a long way from the Royal Melbourne. And this is where we are finding more and more of our nurses, as far away from hospitals as we can possibly get, in needle and syringe programs, in homelessness services. Sometimes we will end up in a hospital because we'll end up in a mental health unit or an emergency department or a plastics unit or a medical unit, anywhere where somebody who may have had an injecting wound might be. What a great opportunity for us to be having that conversation about hepatitis C. We need to be building trust with people who are marginalised. Many of the people that we're working with and caring for have experienced significant stigma and discrimination. The most common place that people with hepatitis C experience discrimination is healthcare settings. So at a time when they are at their most vulnerable and they're not feeling well, they can't necessarily trust that they're going to be treated with the respect that they would hopefully expect. I did my PhD on stigma and discrimination amongst people with hepatitis C, particularly looking at healthcare settings and healthcare workers in 2006. And every now and then I get that mammoth book, 92,347 words of it. As you can tell, I'm not short of a word. So that also goes for the written word, as it turns out. And I look at it and I think to myself, has anything actually changed? That's a long time for the findings of that study to still have relevance. So we have a lot of work to do. I think what we're doing now is being more open and transparent and saying that the stigma associated with hepatitis C is related to injecting drug use. It's not necessarily that fear of contagion as we used to try and couch it, because it was sort of potentially more politically correct and was easier to talk about. Certainly people do wear 2 pairs of gloves and they put on masks and shields and PPE to look after people with hepatitis C, but mostly it's the fact that there is an assumption being made that if the person has hepatitis C, then they must have a history of injecting drug use. So we look at every single person that comes into our care and assume that they're assuming that we are going to discriminate against them, because that's often been their experience. So there's various ways that we have to work and be considerate and be compassionate and give that person the respect that they deserve, because after all, they do have healthcare needs that we have a cure for, and they don't need to live with hepatitis C. And one of the major ways, the most significant ways that we're doing that now is working with peers. So people with living experience of hep C and or injecting drug use. So when Sally's out there in the manual van on the streets of Sunshine, she's not there alone. She's there with Jane and Amanda, who work for Harm Reduction Victoria, who are people who have lived experience and living experience of injecting drug use. Now, they have way more credibility than we do. As a non-injecting drug user, I am absolutely in awe and respect of people who can go and make a connection. There is a shared language, a shared understanding. And what we are now doing is working in peer nurse partnerships so that we can be that trusted person. So Amanda and Jane have the conversation, engage somebody about hep C, and they take them to Sally and they say, Sally is trusted. We trust her. You can get your blood taken, you can have treatment. This is a trusted relationship that we have. And we're seeing these trusted relationships be used across the healthcare system. So in mental health, where there are lots of very complex needs going on, there's no way and no reason for us to have to, as a hepatitis C specialist, to get involved in that care, but we can support and facilitate access to hepatitis C care for 10% of people who have a mental illness are also living with hepatitis C, and they previously were not able to have interferon treatment. So we've got people that often have quite advanced liver disease. So we can use and leverage those trusted relationships. Homelessness services. We can go to the homeless service, but it's the homelessness workers, it's the caseworkers, it's the nurses, it's the doctors that we can just be standing there lurking in the shadows behind, helping and supporting that healthcare worker to get hepatitis C treated and done and cross it off the list. So a lot of what we do is building that capacity. And we're not going to do this by ourselves. We have to integrate hepatitis C into the scope of practice of lots of different healthcare workers and nurses and peers. So in terms of where we are at the moment, as I said earlier, it's been a fabulous success story, and we really do need to celebrate what has been achieved. We've treated close to 100,000 people. I think it is probably about 100,000 now. And that was 43, 46% of the population. But Medicare data shows that tests are declining, and they have steadily declined since 2016. And the number of people treated also continues to decline. So we have a quandary coming up. We've got a 2030 target that's getting closer every single day. And yet the numbers are dropping off, and we're having more and more difficulty trying to achieve those targets. Colleagues of mine at the Burnett have adapted the diffusion of innovation, which is a fabulous concept that was first used in agricultural science back in the 1880s to see how quickly an idea or a concept or a new way of doing things would diffuse through the community. So they've adapted this in terms of the population of people living with hepatitis C. So the willing, waiting and warehoused. What a terrible warehouse. We used to talk about our warehouses. In March of 2016, I think we wrote nationally 32,000 scripts in a month, or at least in a quarter. They were warehoused. They knew it was coming, and they were sitting there waiting for it. And it has steadily declined since then, because then we've moved. So that group were 16%. They were treated very early on. Some of them were even bringing it in themselves through the buyers clubs, because there were buyers clubs set up and there was drug coming in from India and China. So people were actually buying it before it was available on the PBS. The next group, which is the group that we think we probably have just finished treating, is the motivated, but they needed support. So they weren't necessarily in the liver clinics. They were perhaps sitting in their general practice. They're probably aware that they had hep C, but they didn't really want to talk about it. They had reasonable health literacy. They could make their way around the health system. They were engaged generally with some kind of health service. They're finished, they're treated, they're cured. So now we're on the other side of the bell curve, which is where life gets a bit more challenging, because we're now really trying to find people who are very hesitant. They've had those experiences of stigma and discrimination. They've heard the horror stories of interferon. They don't believe us when we say there is no interferon, there is no injection, we promise. They don't hear that. And they need that encouragement. So this is why people and peers have such an important role, because they need to hear these messages from people that they trust, people that look and sound and have their experiences. And then there's the doubtful, the uncertain and the unaware. Now, if we are going to reach our elimination targets, we also need to try and offer treatment to that group as well, often known as the laggards. But we've got to try and create services and innovate so that everybody can be brought on this journey. So we need to do things differently. We need to have a vision as to how we've got this problem, we've done well in the past, but what are we going to do now that's different, that can be innovative to try and reach these other people that potentially aren't where we think we are. Or we could just try and do things that are happening now, we could just try and do them a bit better. And one of those things is data. We all collect data, data is everywhere, and what I've learned is data removes the invisibility cloak. It makes us visible. So you can imagine how frustrated we are when, so just some back of the envelope calculations. So we've got between Q3 2017, which is when nurse practitioners began to start prescribing hepatitis C DAAs, through to Q2 of 2021. And there was a group of 8 hepatology or viral hepatitis nurse practitioners, Sally was one of them, and they added up their Excel spreadsheets, and together they had 970 scripts in that period of time. Based on that, the AHA, which is our professional organisation, did a survey and they looked at the membership of sexual health, alcohol and other drug, hepatology, the College of Nurse Practitioners, and nurse practitioners who'd recently completed Hep B or Hep C training. And they also asked them, how many of you have written a script for direct-acting antivirals? And you can see 78 responded and 53 had, majority working in metropolitan areas, in Queensland and Victoria. We obviously surveyed the right people because this is where our priority populations are, and most of the prescribing was occurring in community health, corrections and alcohol and other drug services. So you think about the 970 scripts that 8 nurse practitioners have prescribed, and then you think about the 53 that have prescribed at least once. And then this is the prescribers for hepatitis C direct-acting antivirals since 2016 Q1, which is when the drugs became available. I don't know if you can see the salmon, let's call it. That's the nurse practitioners. I'm just going to make it a bit bigger. You can see that that doesn't quite add up to over 1,000 scripts over that time frame. So where are the nurse practitioners? The observation that has been made by our friends at the Doherty and the Kirby Institute, because they are our friends, they're trying to find the nurse practitioners. What they've noticed in the time frame that the nurse practitioners started prescribing is the other category started going up. And there's a few nurse practitioners, but the others. So we think nurse practitioners are counted as others. And I present to you once again the invisibility cloak. Because I work with some people down in Geelong who I'm madly trying to find nurse practitioners and they don't understand why. So I showed them this graph and then I showed them the numbers. And I said, nurse practitioners are going to work where the doctors are not. They're going to work closer to where the people are. And we need to find the nurse practitioners to enable them to support us. In New South Wales, I hate to admit it, but they do things well in New South Wales. That really does hurt. But in New South Wales, they're not waiting for the Commonwealth. They're not waiting for the PBS to find the nurse practitioner scripts. They're collecting it themselves. They've said, we know nurse practitioners are absolutely crucial to the backbone of our elimination response. Data is important because data lifts the invisibility cloak. And whenever we think of, this is the care cascade, you can see there's drop-off here. We're testing people, but we're not getting people onto treatment. So wherever you are, I'm really hoping this graph talks to you and that there's something you think you might be able to do, and it might be a conversation, because you just don't know where change and where linkage to care and where encouragement and support can come from. I think this is really important for us. It's a bit of a mantra that I have in my mind. The patients, the people aren't hard to find, we are. So we need to be out there where they are, accessing the services that they are. And this is what many of my colleagues currently do. We can then measure what we do. We can measure how many we test, how many people we treat, how many people achieve a cure or a sustained virological response, and how many patient interactions we have. But there are other things that we find very difficult to measure. So when we're in an activity-based funding situation where activities such as hard outcomes like numbers are being put up as our activity, how do you measure that relationship building that might take months, it might take years for somebody who's been marginalised from a system, that have been discriminated against, but consistently over and over every time they try and access care? This is the real challenge of how do you measure the seed planting. The conversation that we have today may not result in treatment or testing for another 6 to 12 months, maybe longer than that. But one day it will eventually grow and that person will access testing. How do we measure that when we're trying to build a system that's sustainable? And a lot of us are on short-term funding contracts, and it's very difficult to, when numbers is, numbers are the game, but we can't even get the numbers right. So through my work with ECA, I often refer to myself as somebody who lurks in shadows. I can be quiet and my hair can calm down from time to time. So I lurk in the shadows and I say to people, have you ever thought of going to the car park and offering testing and treatment? And they go, oh, it's a good idea. Great, go, do it. So I was very lucky in EC Australia that I worked with some amazing nurses who were really open to trying new things. So Tasmania, prior to this project, Tasmanian Hep C care was all delivered through the hospital. So they didn't really have Hep C in the hospital anymore because the people left to treat couldn't make it to the hospital. They didn't even know that the hospital liver clinic existed. So the nurse down there, Megan, she set up camp in needle and syringe programs all over the state. Most of the time she was in a cupboard. So to have a private conversation, she literally was in a cupboard, and the needle and syringe program worker would often have to go and wait outside because there was no room. So she's performing testing, venipuncture on veins that have collapsed, that there's difficult venous access. It's painful for that person to have blood taken. So that's why the finger prick now is so amazing and has revolutionised testing. She was on street corners dropping off drugs to people who were homeless on a weekly basis, and it was all going so well until one guy said, Megan, what are you doing here? I've still got the drugs from last week. And she went, oh, no, but I haven't seen you for 7 days. Anyway, just kept going. Drugs are very forgiving. He's cured. This is a man who's not lived in a stable accommodation for 5 years, no longer lives with hepatitis C and reports feeling so much better. And you know what? Now has stable housing. So you just don't know the impact of hepatitis C. And she has met people in car parks. She's tested and found 80 people. She's tested a lot more than that, but she has this extraordinarily high linkage to care. This is evidence of person-centred care in action. She will do whatever is required. She will go to people's homes and drop off medication. She will ring them to remind them to take the medication. She's a mental health nurse, so she works very closely with the caseworkers down there in Tassie. What we loved to see was that she we measured all of her interventions. because I wanted to measure the nurse's role. What do these nurses do all day, every day? We can quantify that. And what we saw was she's had, at the beginning, they were quite short, less than 5 minutes, quite a lot of these brief conversations. And over the time of the project, they went out and they were averaging 10 minutes. So she was gaining trust with the community. This project has now just been funded 2.5 million for 7 years. This is the first time hepatitis C has ever been funded in Tasmania. So absolutely remarkable. I still get choked up because we did a lot of work to prove that this model works, because we know it does. And we know that it's not just one person, not one nurse is going to do this, not just the nursing profession. It's all of us working together. And that is the only way that this team approach is going to work. We have to have we have a toolbox, and it's a mobile mindset. We had this discussion last week at this meeting where it's not you have to have a car or you have to have a Vespa or you have to have a van. It is having that ability to be mobile, to go to where people are, to be outside your professional comfort zone, and trust that you're in the right place when people come and start having those conversations with you around Hep C. Incentives. So we do offer people reimbursement for testing, for treatment, for engagement in care. And this is absolutely helping in terms of helping people who would not prioritise hepatitis C because it doesn't make them feel sick now. But it helps them and helps elevate it on their list of priorities. So this has been of great success. The point of care testing, the team, a health promotion campaign. This is one of the things that EC Australia worked on with and co-designed this campaign with people who inject drugs. And this was the sign at the Canberra airport. Canberra airport gave us this for free because they thought it was so cool. So when you fly into Australia and you're driving out of the airport, live free from Hep C was the first message that people from overseas were getting. A very proud moment. And then these are some of the other posters. Get clear while on the gear. We couldn't put that on buses in Brisbane because the courier mail was going to get a bit angry about that. But that certainly has a particular target audience for needle and syringe program users. So it certainly is something that has really resonated. I know I'm running out of time. So I am going to just skip over. This one is a nurse practitioner-led model of care in a community-based setting. So this service had never offered clinical care before, but they've got a needle and syringe program. Can I remind you, all these projects are running out during COVID, which was just so fabulous. Trying to test, trying to offer treatment, often not being able to because of lockdown rules. But this was a very successful project that was also a partnership with peers, tested a lot of people, linked people to treatment. This nurse peer partnership in the Northern Territory has been absolutely inspirational. And what I've learnt about this model is if you get two people with no egos, my goodness, sky's the limit. Because nobody was like, that's my job. Oh, no, you can't do that. It was like, yeah, whatever, let's do this together. And they worked genuinely and collaboratively together. So once again, great success for a space in Northern Territory where they said they didn't really have a problem with Hep C because it wasn't there. It wasn't in their face. They couldn't see it because they were all in the hospital and it wasn't presenting in the hospital. And then finally, this one is something that we're very proud of, community corrections. So this is a setting where people aren't in prison, they're on parole, they might have been released from prison, but they have to go every week. People in community corrections, as it turns out in Queensland, they weren't accessing doctors, GPs, they were getting their healthcare from pharmacies and emergency departments. So when people were offered testing in the community corrections site, they were being referred to testing by their community corrections caseworker who said, come on, do this. You may as well, you're here. And then they get on to treatment. They then started bringing their family and friends into this trusted space. So this model and this setting is a really interesting one that's being explored around the country. Once again, people were found and scripts were written. So I think most of these things I've talked about, that lack of trust in the system, experiencing multiple comorbidities, and not being able to determine if Hep C is actually making people feel unwell. The attitude, well, I've got Hep C, I'm still using drugs, so if I get cured, I'm just going to catch it again. You know what? The PBS funded hepatitis C direct-acting antivirals for reinfection. So we just keep treating. If you become infected, we treat you again and again. And we are seeing this in the prison system where people don't have access to harm reduction. So they are becoming reinfected and we are just treating them again. No phone, no way to be contacted. We know from work that was done at St Bees here in Melbourne, you must always get the mother's phone number because the mother will always be there. The individual sitting in front of you, their phone number might change, but the mother's phone number will always be there and they are a very important resource. And not letting pharmacy dispensing fees become a barrier. Let's just pay it, just get it done so that the treatment is truly free. We deliver medication. We do a whole range of things that are making sure that the person realises that they are doing a public health service and that they are contributing to that hepatitis C elimination effort. So I just wanted to plug here. So Sally's over there. These are some of Sally's colleagues. We're very lucky in Victoria that we have a network of 11 integrated nurses, integrated hepatitis C nurses. They work at all these hospitals, both in metro and regional areas, and they travel out into community-based settings. So the hospital is simply a base for them and to get that clinical governance and that support, and then they go out and provide that care. And I am certainly their #1 fan and president of their cheer squad because they do an amazing job. So I don't think there's any doubt that we can reach our hepatitis C elimination targets, but we've got to start working smarter. We've got to start engaging people who are working with priority populations to ensure that that happens. From where I sit, that's the nursing profession, because nurses are used to working to somebody else's schedule, to working in a person-centred way. From Australia to Brazil to Canada, across the world, nurses are recognised as being absolutely crucial. And I now would say that that peer nurse partnership is that next evolution of that relationship and how we're going to eliminate hepatitis C. So we need to mobilise. We need the data to demonstrate what nurses are already doing, because they're already doing it. But we then also need to measure the effect that nurses are having and the impact that they have, because it is quite dramatic, and in order for us to lift that invisibility cloak. So just acknowledging all the partners that I've had the joy of working with over the last 4 years, our funder, and here's to lifting that invisibility cloak. Thank you.
Good afternoon. I'll do my thanks now. I just want to introduce myself. I'm Krishnasamy. I'm Professor of Cancer Nursing based here at Peter Mac as the Director of the Academic Nursing Unit, and work with Marie at the University of Melbourne and also with the Victorian Comprehensive Cancer Centre Alliance. So that said, ladies and gentlemen, the power and importance of nursing. Jacqui, I knew we were in for a feast. I've heard you speak before. I've had the same response to being quite overwhelmed by an appreciation of the work that you and Sally and so many of your colleagues do. You've given us a tour de force of what it means for nurses to be impacting with marginalised, discriminated against groups of people. It fits so importantly in the context of our capacity and capability to address social determinants of health. You've talked about innovation, you've talked about mobile mentality, you've talked about determination, you've talked about commitment and kindness and respect, and you've talked about data and lifting that cloak of invisibility for us as nurses so that people can see the power and importance of what we do. Thank you so much. There are no questions online. There's one comment, I think, but I'm going to open it to the floor in a moment. I just want to see the comment online. The comment which you might like to hear, Emeritus Professor, is if you have an honorary as an APROF, then own it, sister. Very well said. Thank you to whoever put that in. We are to time, but if anybody has a pressing one or two questions, there will be an opportunity to talk to Jacqui when we go outside. But does anybody have a question now you would like to ask before we? Yes, please do. Yes.
Can I take off my mask?
You can. Thank you.
Thank you. And then you were speaking to it. I don't know this on the screen.
Thanks, Anastasia.
Oh, my no.
Hello. I'm an international student and I had to get my student visa done recently and I had to get a Hep C test done and I had to pay out of pocket. Would the test in the future be like covered for the future for international students getting the Hep C test done?
Oh, what a good question. At the moment, without access to Medicare, it's not funded. And what is more problematic for us is that if an international student or somebody without a Medicare card is found to be Hep C or Hep B positive, they cannot access funded, PBS funded medication. So there are medications that we can access through overseas pharmacies for hepatitis B, and there are some for hepatitis C, but certainly people who are Medicare and eligible are very much at our policy mindset at the moment, and there was a workshop held last year on exactly this topic. So trying to make it accessible. What is the point in testing if we cannot do something about it? So yeah, it is at the moment. Look, let's say it's at the moment it's not going to change, but I've seen things change that I never thought would. So
I just got another question. Is the fingerprint test recently new or? Yeah. It's quite new.
Yeah, it is. So it was approved by the TGA last year in deepest, darkest COVID. Last year, the year before. The years all merge into one. So yes, at the moment that is not MBS rebatable. So where there are various ways of accessing the machine, which is about 25 kilos and comes in a really big backpack. So Sally, if Sally gets one of these, Sally's going to have that. She's going to have a FibroScan. She's going to have backpacks and all this sort of stuff. So we certainly, we want our nurses to be fit. Yes, so that is, at the moment, it is free because it is being paid for by other avenues. It's not the be all and end all, because you often have to have full bloods done anyway. You want to be able to assess somebody for liver disease, advanced liver disease, before you put them onto treatment. So I know that it's a diagnostic tool, and for certainly people with difficult venous access, which is a lot of our community now that we're trying to test, this is a great way. Mind you, when I was doing my point of care testing training, it looked like a bloodbath. Oh my God, the blood was everywhere, but in the little pipette. So yeah, it's quite a skill. It is quite a skill, and it's a different. Yeah, it's just different.
And it's a little machine that reads. It's like a
yeah. So it's a little box about this big. You can have 2, 4, 8 cartridges. You put it in the pipette. You got to do it quite quickly, or else it starts to clot. You shove it in there. It cooks away for an hour. Of course, the thing with a lot of our clients is that they're not there in an hour. So then we've got to find them. So that's where mum's number comes in handy. Hopefully you've got their phone number, which doesn't change in the next hour, or you'll be able to find them. There's a way of accessing them, but it just creates new challenges that we must encounter. Great questions. Thank you.
Thank you.
Yeah, thanks, Yvonne.
Thank you. Hi, that was fantastic. My name's Yvonne Panek-Hudson and I'm a nurse practitioner in clinical haematology. I'm really interested, obviously, in nurse-led models of care, but with the current national and international nursing workforce, catastrophe, what are your plans to lure nurses into this sort of work to sustain these fantastic and innovative patient-centred models of care?
No, you can't have the cancer.
Yeah, I was just going to say, Yvonne, we're going to talk later because there's surely a job for you. Yvonne, that is such an excellent question. Do you know what? Sally, how long have you been working in Hep C? 8, 10?
12, I think.
12 years?
Yeah.
Our workforce is extremely stable because I think once you get into it, you realise how incredibly special it is and what a difference that you can make. My concern moving into the future is the closer we get to elimination, the harder the work is and the harder it is going to be for us to sustain the funding. I mean, that Tasmanian situation, I get choked up because the amount of work that we had to do, and we did not expect that. So very rarely in this world are you ever surprised. But we were absolutely blown over. This is an unusual situation for a government to have such a long-term vision. We are very lucky here in Victoria that our integrated nurses are block funded. So I keep saying, got the safest jobs in hepatitis. In terms of project work, I think that is our real challenge. And honestly, we have so many people wanting to work in Hep C because it's curable. And so many people can't imagine what that would be like after working in drug and alcohol, in mental health, in areas where it's chronic disease. To be able to cure something is really quite remarkable. We have some of the best conditions. The nursing role in Australia, I think, is best defined here and in Canada. You don't have to go far into Europe to realise it's a very medically led model. And I've been working with the Brazilian government who also recognise the importance of nurses and are actually looking, they call it task shifting. I let them call it whatever they want. But it move everything, so actually get the doctors out. New Zealand, we've got CNCs prescribing Mavorite because they only have one drug available for Hep C. So there are so many different models available, but we are certainly, there are not enough, there's not enough stable money, and I really do worry about that. In 2027, what's our workforce going to look like? We won't have reached elimination, but how stable is it going to be? How do we get those people, those amazing venipuncturists who look at a shin and go, yeah, I can get blood out of that, and not be completely terrified, or, you know, look at somebody who has not, you know, has had touch points in the system and go, you know what, I can find them. How do we attract that quality? I'm not too sure. I think we've got the skills. We just, yeah, it's the sustainability issue that worries me.
Yes, take one last question and then we'll wrap it up. Thanks.
Thank you for the wonderful presentation. My name is Lynn. I work in the private hospital in the emergency department. So my question is for you, Jacqui, is from your expert point of view, how a private hospital providers and can contribute in this kind of
Helene,
area.
thank you for asking that question. What a wonderful question, because you work in an emergency department. Do you know where, what is it, Miel, 40%? Roughly 40% of our notifications in Victoria come from hospitals. 40%. There's a lot of testing going on in our hospitals, and emergency departments, they are testing a lot of people for hepatitis C. Now, often they'll be discharged by the time that result comes back. I want people to stop and think, why are you testing this person for hepatitis C? We now have a public health system and a surveillance system that is following up new notifications. So you test somebody in an emergency department and that goes, and it's a new notification, it'll go straight to the public health unit, and then they'll eventually give the intern a phone call who will then have to go, right, who was that and where? Oh, they don't have a GP. Oh, missed opportunity to link that person to care. So if you're testing somebody for hepatitis C, which is occurring a lot, think about what referral pathways do we have in place? Do we know in our area what services? It's probably Royal Melbourne, so it's probably Sally. So, you know, making sure that you know that you can give that person the name and details of somebody that they can contact. Because, yeah, I think this is a great opportunity when people are potentially, if they're not too sick, could be engaged, and particularly if they're then admitted onto the ward. So we have some wonderful in-reach programs that are around that. As soon as a Hep C positive diagnosis occurs, the liver nurse gets a call and he or she will go to the bedside of that admitted person, and often not technically start them on treatment because we're not allowed to do that while somebody's an inpatient, but there are ways around that. So yeah, it is about saying, right, we're going to test, but what do we do if that test result comes back positive? We need to follow it up. Great question. Thank you.
Jacqui, thank you so very much on behalf of all of us. You've given us an incredible time and opportunity to think. You've challenged us and you've shown us a vision of what's possible. Thank you so very much. Thank you to all of you online who joined in, and thank you very much to all of you who've come and given your time in the room. Please come and join us outside for some refreshments. Thank you so much. I've forgotten, I've got another job to do, haven't I? So before I get sort of sacked for my job, just for people, just a flag that on the 4th of April here at Peter Mac, unashamedly, as Jacqui has done, touting for business, we will have a nursing information evening for those of you who would like to come and hear more about working at Peter Mac and the Cancer Centre. We'd be delighted to see you, whether you're online or here in the room. So please look out for that. The QR code there is there for you to take a photo of if you want to hear more. But back to this series, and I think what Marie talked about at the beginning, the opportunity for us across the precinct and far beyond across the state to really turn our attention this year to issues of equity and equity of access. So the next in this series will be a lecture around our Marion Barrett lecture, which will focus on the elimination of cervical cancer. Again, Jacqui, I think coming back to what's happening in our First Nations communities and the enormity amount of work that we have to address there, to address those issues of inequity and suboptimal outcomes. So that next lecture is on the 11th of May. We would be delighted to see you either in the room or back online. So thank you all very much. Thanks, Anastasia.